Hey, welcome back to Her Health MD podcast. I'm here today with Dr. Nichole Cubbage, who is a health researcher and um, scientist, and she's going to share with us some information about vanishing twin syndrome. Welcome.
Hello, Allison. How are you?
I'm good. I'm good. It's been an interesting time lately. So I've had a little break from recordings because work's been busy. And yeah, this topic in general, we've had some talk about miscarriage and fetal loss on the podcast, which I think is really helpful to our listeners. And this specific area we haven't really talked about or addressed. So, but it's something that hits home for me as a OBGYN because, it's something we see in the office, and I don't know, it's just really I feel for my
Yeah.
patient. Yeah.
Yeah, thank you so much for bringing me on to talk about it. I appreciate the opportunity to, spread what I know about it and to also learn more from your standpoint, as a provider. And I was just curious to know how how frequently are you seeing vanishing twin syndrome? And when you do, are you denoting it as vanishing twin syndrome, or are you using some other terminology such as blighted ovum in addition or instead of vanishing twin syndrome?
Yeah, that's a good question. So I think it's something we'll see. I mean, it's pretty common, but I mean, we see a lot of OB patients like any day in the office, and I would say, at least like once a month, I'm seeing somebody who is experiencing this, but it is usually often very early. So we will put it on like we when we see patients, we will put it on their problem list and we'll call this. I mean, I think it depends which doctor did the initial visit or which doctor diagnosed it and exactly what they say, but usually will say that it was a twin pregnancy with, a loss of one of the twins. And usually will denote kind of the gestational age for that. Um, a lot of so for listeners, what we are talking about in general with vanishing twin syndrome is really encompassing more than just twins, any if there's a pregnancy, twins or other multiples, higher order multiples, triplets, if there's or beyond, if there's a miscarriage and the pregnancy continues, so there's a loss of one fetus or one or more fetuses, then this is what we're talking about.
Right, and, that you're definitely correct, and to further clarify for the listeners, there are 3 general outcomes for vanishing twin syndrome, and the first and most common outcome is the blighted ovum, which is an empty gestational sac or a gestational sac where an embryo has ceased developing. And the second most common outcome is partial reabsorption or full reabsorption of the deceased multiple or multiples into the surviving multiple or multiples and mother. And the third option, this is the least common, is I hope I'm saying this correctly, fetus popraceus or propraceus. It's a Latin term that means paper thin fetus, and the loss typically, I think, if not exclusively, occurs in the third trimester, if not late in the second. I don't. There may not even be a clinical uh, threshold for that. Actually, I don't think I've ever seen one in the literature, but it typically occurs later in gestation. The fetus calcifies and becomes compressed against the surviving fetus and the uterine wall. And there are typically remains present at birth when that occurs, although there can be remains present with any of the 3 outcomes, even when the loss occurs as early as 6 to 8 weeks gestation. And I think what a lot of researchers and providers and even patients don't fully understand yet, but we're trying to, is the potential risks that exist for the surviving multiples, as well as the pregnant individual. Because this is not just, you know, N not to get political here, but this this is not just exclusive to mothers, right? This is also relevant to gestational carriers. These health impacts exist for gestational carriers, and so it's really important that we account for that, in the research and the literature. And so, uh, you know, uh those risks, largely for the mother, include vaginal bleeding, cramping, hypertension, um, stress, increased levels of stress, and there are a number of other potential complications, that need further research to explore. And some of the risks for the surviving multiples include, preterm labor, low birth weight, low Apgar score, things like that. And so, yeah, we still have a lot to learn, but those are some of the general
And
outcomes.
I will say, like, as as an OBGYN, what I'll notice is how hard it is for patients who have something going on that we don't fully know about, which is really very common. I mean, again, politics does affect women's health, and we don't have as much information on things that affect women as we do for men in terms of data and
Right.
research. But also, some things haven't gotten, we haven't delved in as much yet. And so I think for patients and for women who are listening, and wondering, you know, what what does this mean if I'm going through this? And what can I expect? I guess that's something that I think is a hard. There's a lot of unknown there. Um,
Yeah.
yeah.
Yeah. I'm sure that makes it hard from the provider standpoint to guide your patients appropriately, when there's not a whole lot of literature, and the existing guidelines that are out there, and I'm not gonna go into specific bodies on this podcast. I don't want to call anybody out, but there there are guidelines. Most of them are relevant to twin pregnancies in general, but there are very few that are relevant to VTS, and those that do exist, are largely outdated, and need improvement. And without those guidelines in place, even the initial diagnostic standpoint, where most of these cases are found in ultrasound, they if that initial point right there is can't readily identify vanishing twin syndrome, or denote it in a way that allows the subsequent providers to adequately care for that patient, and then that can be very tricky. And so, that's part of my work, is to help improve the guidelines surrounding vanishing twin syndrome, but also other types of multifetal loss, or multiple loss, I should say, both during pregnancy and postpartum. Um, yeah, so, and we are working on that together for our listeners right now. How are you feeling about that? We're starting a foundation. We're starting a nonprofit.
Huh.
How do you feel?
Yeah. No, it's very exciting. I mean, there's not enough information available. And
Hello and welcome
yeah, I
back to
mean,
the
it's an area
podcast.
where there's just so much we can explore.
Yes.
So yeah, I'm excited. In my experience, I think um the general way that it's been approached, or when first of all, the diagnosis is tricky because, like you said, usually ultrasound. um we know for sure when we get an ultrasound and there's viable twin or multiple pregnancy, and then we subsequently see that there's a loss, that is our most obvious and clear diagnosis. Sometimes we'll get our early ultrasounds, usually around 8 weeks, where we're just establishing the due date, confirming that the pregnancy is viable, and we see something, and maybe there's a little sac there, a little cyst or something, and it could be, that it was a twin that has not developed very far. And so these things I think are more tricky because we're kind of like,
Yeah.
this is going on. Oh, no, for sure. Of course, our later losses are, um, also, like you said, they can result in more likely, remains at birth and potentially more obvious concerns or effects that there's more data or study on. And I think one of the things that we always look at when we know for sure that there's a twin pregnancy and there's a loss is, well, do they share a placenta or not? Because that
Yeah.
seems to make a difference. Or so there's definitely, and I would say that we have more information on some of the later and more complicated things and earlier stuff. We're concerned that that this is, sometimes it's just getting treated as a singleton pregnancy. And, we feel that this is maybe an oversimplification or a missed, that we might be missing the need for serial growth ultrasounds or antenatal testing towards the end of pregnancy, like things that, and we need to justify these things in today's world. We need to have a reason and diagnosis that justifies to insurance companies that, gosh, we do need to do these ultrasounds and do this extra stuff.
Yes. Yeah, I agree. And you really hit on a point there. Even if just in passing, it's like this is one of the things I think that we don't really think about when we're talking about vanishing twins. Not necessarily you and I, but in general, in any space where it's being discussed, is the fact that it is not just a loss of multiples, because that word, similar to the word miscarriage, kind of distances us from what is really happening here. There is, a cessation of development, or a cessation of life, depending on who's defining it. That is, that is really important to consider, because it is unlike a, I guess what you would call a normal miscarriage. And I don't like using that term, but a normal miscarriage where, you have remains that are excreted from the body. There, with a lot of multiple pregnancy, especially in cases of vanishing twin syndrome, you lose one, the remains of the deceased multiple, probably won't leave the body. And so that's when they get reabsorbed into the surviving fetus or fetuses and the mother, or they have to be surgically removed. That is something, it's a missed miscarriage or an incomplete miscarriage, because the remains never actually leave the body, unless they're, operated on typically. But that's I think what makes it a very unique and hard form of loss. And so even if you have a set of twins early on, and let's say even as early as 6 weeks gestation, where the literature has even shown there can still be some risks, the I lost my train of thought, sorry.
Sure.
Um, the surviving, multiples, they still have risks. And, it's, yeah, it's just a strange form of death. And I think that, when in the clinical setting, you have one healthy baby, and it's easy to kind of now treat this as a singleton pregnancy. And then when I had vanishing twin, that's precisely how it was handled clinically. I was not given the extra ultrasounds that would normally accompany a multiple pregnancy or anything like that, because even though the remains of the deceased twin stayed, the last time we saw was a 24 weeks ultrasound. They they were, I don't know. They stay. So it's a really it's interesting to think about why that's treated as a singleton pregnancy, because it's almost, like it is completely disregarded that other, and I don't wanna be so, so biased and call it a life, but I'm speaking here as a mother who's gone through this more than anything now.
Yeah.
You know, when if you feel that loss of life, it's important to have it acknowledged, and, and your care protocol doesn't account for that. And even at birth, when the birth certificate, um I had questions about how they were gonna label, the surviving twin, a multiple, if that multiple was never actually born alive,
Right.
And then also, would that multiple receive a death certificate if they were never actually alive? And the answer was, well, if they went through a funeral home, then they would get a death certificate, and they would only have to go through a funeral home if the provider on call determined those remains to be human. And, that just felt like, the decision of how the kind of the family wants to decide something. And, from a clinical standpoint, from the legal standpoint, of course, we have to have a limit on what we define as like human remains, right? For hygienic purposes in society, right? We can't just be taking carcasses home from the hospital and things like that. But, it's hard because I had questions about, well, okay, if the remains reabsorb into the placenta, can I take my placenta home? And if there's any bit of those remains still present, are they going to constitute something, quote, human, as deemed by the state, the hospital, and the provider, and last, the patient, myself and my family, and that was, it's very, I think, interesting to think about from that perspective. Um,
And so what did they determine? You know?
it's actually, on they did not put my whether my daughter was a singleton or a multiple on her birth certificate. My daughter was actually born at home, and so I didn't have any medical personnel present
Yeah.
at the time of her birth. And when we called the health department to get her birth certificate, first of all, they didn't know how they were gonna get me a birth certificate because they hadn't had a home birth in a very long time that did not have any medical attendant
Right.
whatsoever. So the
Clarify, it
poor
wasn't like
young
a necessarily like a planned I remember now, it wasn't necessarily a planned home.
No, it wasn't planned. I
Yeah.
mean, it was, well, let's say it was planned for, but it was not something I wanted.
Right.
I
Yeah.
I hoped in my dreams that it would be something that happened so easily and so fast that I wouldn't even have time to react. And man, there's something to be said for the power of the mind, because that is precisely what happened. I envisioned it, and there were multiple times where I would just be in the bathroom on the floor, sitting there and
Yep.
holding my belly, saying, you know, holding my child, saying, "We're gonna get through this. You are so strong, and all the women before us they were so strong. We do not come from weak stock. We are strong, and we got this. We got this." And I, as a scientist, as a researcher, I knew the statistics, on childbirth. I know how many women throughout history have died. I'm not somebody who, promotes, free birth, and I had no shame to those
Right.
who do. We're all entitled to our own opinions. But it's not something, that I wanted to. I actually tried to get midwives, and I tried to barter with them, because, we to afford a home birth, that's very expensive. And I was a student in my master's degree at the time, and my partner was also doing his master's degree at the time. And, things were a little tight. And then it was also in the middle of COVID. And so that threw a wrench in.
Yeah.
A lot of midwives weren't doing home births at that time. And so, to get somebody in, it was impossible. And it happened. I actually purchased, like, waterproof sheets, sterile umbilical cord, scissors. I educated my partner on signs of postpartum hemorrhage, and we made a plan, that at the end of labor, right before I gave birth, we were going to call for 911 to get an EMT in case something happened and I needed transport. Or Hazel needed transport. And that's precisely what we did. They showed up. She was already delivered. They were there for the delivery of the placenta, and which did have a hard nodule on it, even though the loss occurred somewhere between 5 and 6 weeks gestation. Um, and um, and we cremated that placenta. We cremated it ourselves and saved the ashes. Um, but yeah, we definitely used the waterproof sheets, and we definitely definitely used the sterile scissors, and she ended up being very healthy. I'm not going to lie, getting her into the pediatrician without a newborn screen was a little difficult. They were being stiff with me on it. And But we eventually got her in. We got her all the things, got her squared away, just checked out, even though I knew she was healthy. I had the EMT verify her APGAR score, make sure, yeah, we're good, you know. I
Mhm.
signed the declination form, and out they went. And I sat at home that evening, and it was very peaceful. It was, unlike my first labor, which was 31 hours, and I had the cascade of interventions in the hospital. It's very different. And I felt very strong afterwards. But it was yeah, it was a fast labor. Is that something I wanted? And it's honestly, I would never wish giving birth alone on my worst enemy. That is terrifying, honestly, for any any woman.
Yeah.
That's terrifying. And you as a provider know that, even in a hospital setting, you can struggle to save somebody's life who's hemorrhaging, even with all the materials right there in front of you, and
That's very
so
true. Yeah. 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 Listeners, I would say, as an obstetrician, like, I'm not a big fan of home deliveries, like, just because of that, because the reality is that things sometimes are going great and then that happens. But I
yes.
do recognize that there are situations where, um, women that were patients, that are, not able to get the care that they, like, desire for. This is a reason that this can happen because there's a failure in the system to, like, really recognize what's going on and have, like, a helpful approach to it, and so you feel backed into a corner. And that happens sometimes with other situations as well. Women who don't want C-sections that are, recommended, and various, other, things that
Right.
could pop up, and it is something that is problematic, um,
Yeah.
in our system.
Okay. One of the questions I get all the time is, well, why didn't you see a different provider? And well, I did. So I ended up going all through the same practice where I had my first child. And I had different OBGYNs and midwives, many of which I saw again during my first pregnancy. They were all outstanding. And By the time we got to really kind of my wits' end, where I was really consider preparing for birthing alone, because I didn't feel safe. I didn't feel that my unborn child was really cared for. I
Mm.
did not feel that the life of the child I had lost was regarded. And I felt that, I was not met with understanding, in a lot of scenarios where I brought forth evidence. Um, I would bring in articles, from PubMed. I would say, "Here's what I know, here's what I did," because they would tell me they didn't know, and so I would bring in the research, and I
Mhm.
would show them. And the thing is they weren't, willing to learn. So by the time I got to the end of this rope, and they even suggested that I consider leaving the practice, it was already too late in my pregnancy to jump into another provider. I was over 24 weeks at that point, and most providers won't take you. And so I was just kind of on my own. And that was when I knew, that I was just gonna really have to prepare for the worst and hope for the best. And, being myself, I really did plan through options A through Z. I wanted to be as safe as I could for myself, for my child, for my family. I didn't want to end up dying in this whole process,
Yep.
right? I didn't want my daughter to die. Um, and so this is, yeah, it's not, like I said, it's not something I would wish on my worst enemy. I felt strong by the end of it. But I was also very, very sad by the end of it. And yeah, but I was glad it was over. And, now I've never quite been able to let it go. So that fueled my doctoral research, and that fuels the work that I do now. And yeah, and I just hope that, we can educate and spread awareness, and, establish a foundation that serves as a community for people. There's foundations for all different kinds of diseases and things like that. And we just, yeah, we don't have anything for Vanishing Twin that is specific for this community. And so I think that that's important. And there while we're not going to provide any counseling resources, it will still be a great community. And for the listeners on this podcast, there are a number of counseling resources, a number of support groups. Just to name some of the foundations, even that you've spoken with previously on your own podcast, Chasing Rainbows.
Yeah.
Yes, they're amazing. Footprints, twin and triplet loss support based out of the UK. They're amazing. The Sky High Foundation, who I'm partnered with, they continue to push the Purple Butterfly and the provider training and patient resources into hospitals all around the world. And right now they're currently working in the United States. They are also based out of the UK. At iCombo, the International Council for Multiple Birth Organizations, is a wonderful resource for people who are multiple parents. But there are also some resources on there for parents who've experienced the loss of multiples as well. The TAPS Foundation for Twin Anemia Polycythemia Sequence. Stephanie Ernst is based out of the Netherlands, and she runs the TAPS Foundation. There's also, I think, TTTS International, Twin to Twin Transfusion Syndrome International. I think about that one. And yeah, there's a number of them, and so those are all some of the really unique ones. And the Footprints in particular, I think Chasing Rainbows also has very regular support groups, and lots of good qualified people.
I wondered which resources might be good for people to connect with others, because that's something that's so tricky when something's not super common or super
Right.
understood. Uh,
Yeah.
that having support and talking to other people who have been through it seems to be a huge need.
Right.
Um, I see a lot of I'm in support. Well, it's like an online group for OBGYNs also who are moms, so that may change, it's not just random, but I mean there's so much compassion and tenderness and kindness and a concern over patients. And then there's just I see in other spaces a lot of frustration and anger towards OBGYNs. And sometimes it's hard to just even get up in the morning and go, because it's we feel like, people paid us, but we literally are putting our lives on the line, missing time with our own families. And really, I'm heartbroken because, just right now, I'm heartbroken because a patient, lost her baby last week, and just some other difficult diagnoses, just feeling for my patients. And I think that just our system is bad, in a lot of ways, where patients and women were not feeling supported by the medical system. And a lot of that, I think, is the things that come in between, that there's There's a lot going on with the insurance companies that like what issues in terms of care and then just in terms of sustainability, like it's not really like possible the way it used to be to just like have your own practice and just like see your patients. So most of us have to work for some company that then tells us that we have a schedule where we have to see, 5 patients an hour, 4 or 5 patients an hour, and you have to be like really quick. And then of course the liability stuff, that takes away from, being able to maybe go out on a limb for a certain patient in terms of doing something that's not like standard of care if that's what they want, because,
Yeah. Yeah.
so I think, we need to, I hope that our country will like look at that and want to, make changes to healthcare. But lately, I'm seeing us going in the other direction, which is why it's hard to keep going.
Yeah.
'Cause it's
Yeah.
like,
I truly hope, we see some changes because as a country who spends so much on healthcare, more than any other nation on healthcare, we have some of the worst health outcomes. Okay. Oh, I can hear you now.
oh, you can. We're doing this research, and we're getting these great options for medications and treatments, but they're not accessible because of our setup. Maybe a few of these really well, people can access it, but generally, like we're spending the money and we're finding things, and then we're not making them accessible to our population.
Yeah. And even further to your point, provider education, is it doesn't really cover too much on women's health. And there are pushes right now to change this. I have a couple good friends who, recently graduated from med school or in med school, and they are, trying to change the curriculum. And I think that's amazing. And we should definitely continue to do that. We need to keep studying women's bodies, and they also need to be included in more research studies, not just in medical school curriculum, but actually in research studies we need to include more women. And one of the things that I recently heard about was the step 2 apparently eliminated the step 2 exam that providers have to take in residency, I believe, eliminated a portion or something on communication. Are you
Uh,
aware of?
well, I'm not like totally up to date on the step one. Is those steps, yeah, are during medical school. I know when I was doing it, we had 2 parts. Like, we had to for step 2, one of the parts was we had to travel. Like, I went to Philadelphia and go to a setup where you saw mock patients, and so you had to have the communication skills and all that. So,
Oh.
what what you're talking about, did they change that or got rid of that?
Yeah, there was somebody who recently informed me, and I haven't looked into it much further, that they did away with a component of step 2 that pertained to provider communication. And apparently this is, that we were just discussing reasons for poor provider communication, especially around miscarriage in particular, but
Yeah.
just generally speaking. And so we were talking about, why people hate providers. I think that there, are certainly larger systemic issues that play into, the lack of trust in not just the patient-provider relationship, but in our healthcare system. And it's not just, it's not providers' faults. And there are things like we're discussing now, like the very education that they go through, the licensing, the testing, and it's nothing, it's nothing personal. I think we have so many providers. It's rare that I find a care provider that I feel truly doesn't care, and I have come across them in my life, right? I think we all have, but I can confidently say that the vast majority of the providers that I know, and I've met quite a lot, they care. They were serious about that
They're
Hippocratic Oath.
probably burnt out. Like, not like but it's like a thing that gets put on like the doc or the provider or whatever. It's like, "Well, the signs of burnout, here's what you can do." But it's like, well, like, dealing with life and death situations on a regular basis, and then, you're just, supposed to go in the next room, like not lose time or whatever. And, it,
Mhm.
um, I just feel that that takes away from, it's just hard, to,
It does.
it's, it's hard. You have to keep your compassion, like, and, you know, you need to, and, I just think that they're they're not giving enough time in the schedules for the doctors to, really, like, if the providers that were with you were able to sit and read the articles you brought and, like, spend an hour with you, like,
Yeah.
have been
Yeah.
different, and then they could have come up with, like, a well-reasoned, educated plan about that.
Yeah.
I mean, I also feel like in your situation, I don't know, did they refer you to, like, maternal fetal medicine or anything?
No. No, there was no reason. There's no risk, no sign of anything wrong or, any elevated anything. The only thing that did come back abnormal was the NIPT. I had the increased risk of a trisomy, because they warned me about this
Right.
prior to undergoing NP. Yeah, for the listeners who may not, I know you know, for the listeners who may not be aware, the NIPT results can be skewed because of the extra DNA from the vanished twin. And a lot of companies warn about this. At the time that I was pregnant, I was told by my providers that the only company that we could send my results to would be Natera. Every other company at the time would not accept my samples because I had vanishing twin that had been diagnosed. I've heard and have seen in the literature that this has since been expanded to other companies now, but they just give more disclaimers on it, is what seems to be the case.
Us their testing to be able to, like, to address that. I mean, I assume they have to have, you know, enough data and, with, patients who have the vanishing twin in order to be sure of the accuracy, even though it's like potentially less accurate, they have to make sure that it's accurate enough for it to be an appropriate test.
Right. Right. And so it usually is accurate, but there are risks. And so, it turned out, Hazel was very healthy. She did not have any trisomies. Um, and so yeah, that's something that certainly needs to be developed more, is the genetic testing route. But you are right about the time, that providers have, and I'm not gonna lie, and I've been very I'm somebody who's very critical about my own decisions.
Mhm.
Yeah, I really, really try to think through things, before I make a choice, and I really try to weigh all options, and I for the longest time, I used to wanna go to medical school, and then there was a time where I wanted to do, like, a dual JD MD or a dual JD or a dual MD PhD. I thought about a couple different options, um, and I really, really, once I got to the end of my undergrad, I was so young. I was so young, I was still
Mhm.
only 20 years old by the time I graduated because I started at college early, and I thought I kinda wanted to have a family, but I knew I didn't wanna wait too long to have one, but I also really wasn't sure about, the quality of life. Even once I had children and I went to med school, I really wasn't sure what my quality of life was gonna be like, being a doctor after then. And I asked a lot of questions, I met with a lot of people, I shadowed a lot of people, and I talked to my friends at the time, and I really love medicine and I love healthcare. And I realized that, I didn't have to abort working in healthcare or abort helping people, all because, yeah, I may not want to go to med school, but it was something at the time that was just kind of starting to come out, this poor work-life balance that providers had. It wasn't really being discussed even too much then at the time, and that was 2014. And
Yeah.
now I think it's a lot more open. We're hearing, more about provider suicides, the poor work-life balance, how the younger, fresh out of residency, are all getting the worst hours, and they're usually, the younger people, they're having kids, that's the time of life where they're all having kids and they have the worst hours.
It's very challenging for young women, especially
Yeah.
because it is a higher frequency of infertility because women are pushed to wait until they're older when their ovarian reserve is less. I personally didn't do that. I had my first when I was in medical school. So I was in my 20s when I had him. And luckily, everything went fine. But I mean, that's also a psychosocial nightmare to be a medical student and have a newborn and then start residency. I was not even quite a year old when I started
Mhm.
my residency, which was worse even than medical school. Um, and then, my second one I had late in my residency. And yeah, that was really hard too. And I think because I was so there was so much demand on my time, to and so hard. It was I think and there's so much pressure to like do well and be perfect, and especially a woman in a surgical specialty
Yeah.
room. Sometimes the more intense surgeons are not super kind and gentle, like, or may approach communications in a more masculine manner, and it's intimidating. Um, so I do feel like part of that, like, was overwhelming. There's a lot of female physicians who do end up in abusive relationships, and I was one of them. And I think that part of that is that you're used to kind of being treated by seniors and even
Yeah.
in my case, it's more common his husband to potentially not necessarily be physically uh, abusive, but to express like emotionally aggressive, and 90 high percent of my patients and their husbands are amazing. Like, but there's definitely like they want to control the situation and they they're I just believe that they are more likely to think that they can be, more aggressive towards the female than they would necessarily with a male provider physician. So we get kind of accustomed to that.
Yeah.
So childbearing, within the context of medicine, you're not wrong. It's that's a very hard thing
It's so hard.
to wait. And yeah, I mean, there's a lot that needs to happen. But, what I was thinking and taking away when you were telling your own story was just that you shouldn't have had to, we should be able to have, you should be able to have the option to deliver in the hospital. And we should be able to figure out, well, ideally, the reason we want to work on this particular topic is so that there's an established, accepted approach so that we know is this placenta, which does potentially, and as you saw when you saw that placental nodule, contain some remains, or not, and how are we going to classify this? And will there be a birth certificate or a death certificate, or will there be I mean, because it is more complicated. When we have a miscarriage for somebody at 6 weeks, we have certain protocols. They can have surgery. They can have, they can take medication, or they can wait. But eventually, if it doesn't pass because of risks, like we would do something, or we would do surgery or medicine. But with a twin pregnancy, as you stated, like we don't that tissue, even small and potentially reabsorbing if it's very early, or not, is still there. So there are risks, and so but it would be good to have classifications, accepted ways, so that you don't feel pushed aside when you're dealing with something that's more complicated than a routine singleton pregnancy. Um, and I think there's other reasons why people also feel like they're not being able to deliver at the hospital where they would otherwise feel safest. So,
Right. Right. And, that's really important at the end of the day that, each patient's like cultural and religious views. And, this is not to say that those of the provider don't matter, right? Because I've heard the arguments on both sides, the providers who may not feel comfortable delivering certain services because of their own views. But this is to say that the patient's views do have to be acknowledged. And, in certain religions, like, let's say Catholicism, for example, where they view the beginning of life at conception, there may not be any remains visible in a placenta, but if they know that there was something there, that was lost anytime after conception, then to them that might be a life lost. And whatever happens, whether there's remains or not, they will be human remains that are resorbed into the placenta.
Huh.
And that, from my standpoint, also, I know my experience was it's not the same as everybody else's. It seems, based on the research I've done, and my own bias, comparison,
Huh.
it seems to be the more common experience. But there are some providers who are very good at explaining the potential side effects. But in my case, as in many others, they did not. They told me that there wouldn't be any bleeding or anything like that. I did have some spotting, eventually, after my initial appointment where I found out. And then I also developed some cramping. And I was very nauseous, but the nausea, could have just been from pregnancy
Yeah.
as is, right? And so could have the bleeding and the
Right.
cramping. All of these are very normal, right? So these
Right.
also, and the research you and I are working on right now, we discuss how these are confounders,
Right.
because they're not exclusive to vanishing
That,
twin syndrome, which makes it even more difficult, to discern clinically what is really happening from where. But what I kind of like to equate this situation to is, and it sounds very brute, is a dead fish in a fish tank. And that's not to dehumanize the fetus or fetuses here, but that is to say that to liken it to that situation where when you have something that has died, in this
and
contained
so
space.
have 2 fish tanks in our house, so
Yeah,
it's giving me quite visually.
yeah. Yeah, I mean, but it makes sense then, right? Because how can you can't, you as a fish, somebody who's had a fish tank, that you
Or
cannot have a dead fish in your fish tank and your other fish will survive. And it also, they know the other fish has died because they can smell it. The ammonia changes in the tank, the nitrates, whatever, all that changes. And there is absolutely no way, even if they are separated in separate sacks, Jerry, except and have separate placentas. It is my own personal inclination, my mother instinct that tells me that they know. The babies know. The surviving baby knows. And you know what? I think most pregnant individuals can also sense it. I personally, I sensed it. I'm somebody who's very instinctual. I truly follow my gut, and I actually knew I was pregnant with twins before I went in for that first appointment, and I knew something was wrong despite not having any signs that anything was actually wrong.
yeah,
And so, yeah, it's definitely, yeah, I think, how could it be unnoticed? I think, to kind of dismiss that is anyone who does that is remiss. And yeah, I think that's just very short-sighted. To what degree, it's still unknown, and it varies based on circumstances, timing of death, cause of death, and the type of multiples you have,
right.
among other factors, right? So, but
Like,
also,
I was
go
like
ahead.
pregnancy, those risks are more obvious, or we have, or something more, yeah, I mean, where we're okay, know that, these monochorionic twins and they're later and this baby dies, that it's like we talked a lot about that even like in my training, like that if there's a concern, like if this baby dies, this baby's under like a very acute situation for a certain amount of time, like very, very high risk. And then, still, but if it's early, these things are still, they're still risks, but they're less like known or established or understood, I think. Um,
Yeah,
before you would say be at a point of fetal monitoring or viability where we would like be ready to deliver if this baby's distressed, then it's like a very different approach. But sometimes it's to the point where it's just being treated like it was just, this was just one baby when, that's not really
right.
what's happening, or, these risks are being overlooked. I also think I would say that even as we work to develop and other people work to develop more understanding in this arena, um, there could be benefit to just being like straightforward, like however you're gonna code it, like just approaching it as a more high risk pregnancy, even when things look good, and potentially like I have a low threshold too. Sometimes our MFMs might get annoyed, but like we refer to like MFMs or maternal fetal medicine specialists or high risk obstetricians who can, they probably already had, like while the midwife or the, generalist obstetrician, we might be less familiar, like, or yours may have been like slightly less familiar, referring to that doctor who's a little bit more knowledgeable. Even it just could be more comforting, like, even if they're like, let's do growth ultrasounds and monitoring. Like, we don't have great data either way, but we know there's higher risk. Like, let's just keep a closer eye. And they know the studies because they're subspecialized and did like a 3-year fellowship in high risk obstetrics. Like, just like even doing that could make a big difference.
Yeah. Yeah, it could. Also, I think, just one easier solution from the clinical standpoint is just, at least with regard to BTS, is earlier monitoring.
Uh-huh.
A lot of nations don't even see they don't see the patient for the first ultrasound until like 10 to 13 weeks,
Right.
by which point most VTS cases will have already occurred,
Right.
more than likely, because, right, they typically occur in the first trimester,
Yeah.
and they fully vanish more often than not, and so there's typically no remains to be found, by that point. And so, but there could still be consequences despite there not being any remains.
Right.
And some of those consequences we're only just beginning to understand. And I'm always very cautious how I try to talk about it, because I don't want to mislead or, say the wrong thing. But there have been, propositions, that epigenetic alterations can be passed down, changes in methylation, histone modifications. But then there can also be fetal microchimerism, where, the DNA is reabsorbed both into the mother, but even the surviving children can be chimeric as well. And there are still further studies that are needed to kind of explore all the ways that this could potentially different happen, especially in configurations larger than twins, so triplets and quads.
Yeah.
There are some really interesting scenarios. I recently spoke with a woman who has both a conjoined twin and is the surviving twin of a vanished twin event. She was a triplet, and so that was fascinating. She has 3 kidneys and 2 ureters and an
Yep.
extra set of DNA in her body, and
Wow.
she had a spare arm in her stomach.
Oh,
And so, and I don't, it was we were there, I was discussing with another colleague, like, precisely how, this could have happened. And just speaking from, the standpoint of how, the twinning events evolved in the order of this sequence
yeah.
that unfolded. And there's just much to be explored. It's very confusing because, I don't know about you, but when I think about vanishing twin syndrome, right, most of us, I think we really kind of first think to twins.
Right.
But things can get very confusing when we start having triplets and quads.
Right.
And, there can be multiple scenarios of different events that can unfold. And it's just tricky, especially when you don't have that earlier monitoring. Now, in
Yeah.
cases where art is being used, right, which is increasingly happening because
Hmm.
women are becoming less and less fertile, they're having babies later. Not to
Art,
mention just, go
like,
ahead.
oh, just for the listeners, like artificial reproduction, or I
Oh,
mean,
yeah.
you
Yep.
could,
Yep.
uh,
Multiple embryo transfer. The more embryos you have, the higher chance of BTS you have. And, also environmental factors are impacting fertility, but even naturally,
yeah.
twinning rates are increasing, again, due to increasing maternal age. So, like, a lot of these things are kind of interrelated,
Yeah.
but we are seeing, increasing rates of it. And so I think that's only going to become more relevant as time goes on, um, unfortunately.
Yeah.
Yeah,
Yeah.
unfortunately. But But yeah, so we definitely need some earlier monitoring, as early as possible, I think. And I know that's tricky, right? Because you can only detect a heartbeat from, really about 6 weeks gestation.
Right. So we'll usually schedule our new OB patients around 8 weeks and we'll do an ultrasound. But I will say if they are using assisted reproduction, they generally have ultrasounds even before we would detect a heart rate, like
Right.
just monitor
Right.
and serial HCGs and all that. And it's also tricky because you have to like justify like risks and benefits and prove that like this early ultrasound is worth it. Insurance. I mean, like it's even hard to get like the dating ultrasound and a third trimester growth ultrasound. Like some, like they will definitely pay for an anatomy ultrasound, but sometimes like the other stuff is tricky. So yeah, I mean, it's all about the data and the evidence and getting that out there to support so that's worth it to the payer.
And that is one of my hopes. I'm not gonna name names here, but I am really hoping that this prospective partnership with an institution that has shown interest in the Butterfly Project up on the East Coast is looking to implement the project formally at their institution. And I am hoping, we've already been in early discussions. We're hoping in the fall that we're going to be able to commence the IRB process to assess the formal implementation of some of those materials so that we can gather that data and push for further changes in the guidelines and policies. And yeah, it's definitely not going to happen overnight, right?
It take time. And I think one of the important things in the meantime, and for the listeners and people who may be going through this and experiencing this, is to find that sense of community. Those resources you listed are great, and finding other people who are going through that. And find doctors who will listen. They don't have, and nurse practitioners and midwives, whoever it is, just find somebody that you feel will listen. They don't have to know everything. If they're willing to take that article and look at it, like you're in a good shape. And,
Yeah.
if they're willing to refer you to like, the high risk doctor for the things they don't know or for the suspicion that it may be high risk, even if it's you know, just for a one-time referral and then, whatever. But those would be things that I would say would be helpful in the meantime while we figure, out like more guidelines, do more research. And
Mhm.
also, like, this is, rare and underserved, and you're also not alone. There's like one of the things that I'm really passionate about in general is connecting with uh, women in all areas where they're, experiencing this is something that I see a lot, whether it's somebody who has ovarian insufficiency or somebody who has endometriosis that were oh gosh, like these things weren't diagnosed right away or treated. Well, these are complicated things and we don't have enough data. And, find somebody who will listen and they'll help you, figure out what needs to be done. That's the most important thing. And find community. There are other people going and not being alone, I think is really important.
It is. And I want to say that back to you too, because you're not alone and you're an outstanding provider, and don't let the system, get you down. I know you wish you had more time with patients, and there's only so much that you have control over. But you are a hero and you are admirable and you are one hell of a woman and mother. So
I
keep
take
rocking it, Allison. Keep rocking it.
I have with I don't when I'm in a room with a patient, like, yes, I want to stay on track, but sometimes people need more time, and some people don't. It's a
Yeah.
routine kid, and they're on their third kid, and they're fine. So I listen to the heart rate, and they're ready to move on too. So I that balance. Thank you.
Right.
It was great
Yeah.
podcast.
It was great talking to you as well. Thank you so much for having me on. I appreciate it.
All right, great. All right.